baseline for today, 28th of March. This is our session for this month. We welcome you. We have so far 55 participants on call, and I think we are ready to start. This session runs for 1 hour, and we have one every month. We hope that in the future we shall be able to run more sessions. My name is Anna Kaguna. I'm an emergency physician. I'll be your moderator for this session today. On call and our experts for the day, we have Dr. Okelo Ambrose, who is an emergency physician working with Mulago National Referral Hospital. He's a time-seasoned physician, and I believe we shall learn a lot from his well of knowledge. Just keep it here. Please stay on call till the end of the session. And our case will be presented by our co-head doctor, Henrietta Lunkuse, who is a fifth-year medical student at IUIU. She took time to prepare the case, and she will be guiding us through this case-based learning for today. And we shout out to the mentor, Dr. Wangoda, who prepared hand-in-hand with Dr. Henrietta the case. So just a few ground rules. Please do not talk or type if it's not necessary. The host will unmute you in the event that you need to speak. You can feel free to send in your questions in the chat during the course of the presentation or even at the end. We welcome all sorts of questions for this session. Once again, I want to welcome you for this session today. And our theme is about we shall unfold, but you have our caption, keeps dripping. So we want to know what is that keeps dripping. And just an overall, in the emergency department, we usually see patients or people that you have no idea how the patient is going to unfold. So the role of these cases is to help us to see how a typical emergency department runs. So we shall have our expert and our presenter to take us through this case. Welcome, Dr. Lunkuse, to start the case presentation. Thank you.
Thank you. Thank you, Dr. Anna. Good evening to everyone on call.
Henrietta? Do you need some time to start?
Presentation is a 9-8-year-old female who has a past medical history of chronic anemia with transfusions for 2 years. Management as elements of the underwear with fresh blood, CI, weakness, and had no more. Please. Yes.
Dr. Henrietta, you're not audible. You might have to repeat the case again because we missed you. Sorry, guys, about that. We are in touch with Henrietta. I think it's a network problem, but she'll be back soon. Sorry guys about the network glitch. We are working on it to ensure Henrietta is back on call. Just give us 3 minutes and then we shall restart afresh. Dr. Henrietta, you're welcome back. We are going to request you kindly to start afresh. We missed the big part of the presentation.
Sorry, apologies. Good evening, everyone on call. Today's case presentation is of an 8-year-old female with a past medical history of chronic anemia with transfusions for 2 years. Her presenting complaint to the emergency department was intermittent soiling of the underwear with fresh blood for a week. The associated symptoms were progressive general body weakness. However, she had a normal appetite and normal bowel habits. The primary survey was done. Her airway was patent. She was breathing spontaneously and she was not in any obvious distress. Her circulation, she had severe conjunctival pallor with blood pressure of the systolic was 106 and diastolic was 61. Her pulse rate was 78 beats per minute. She had warm extremities. Disability, her Glasgow Coma scale was 15/15. Her pupils were dilated 4 millimeters, were equal and reactive to light. On exposure, she had no prepubertal signs, for example, presence of pubic hair, nor breast enlargement. She was a febrile with a body temperature of 36.4 degrees Celsius. She had soiled underwear with fresh blood, no signs of sin. So on the sample history, her symptoms and white mucosa, both conjunctival and buccal. She was tired looking with fresh blood, soiled underwear. Allergies, whether food or drugs. She was on iron and she had a history of iron and folate medication. Her past medical history, she had a history of severe anemia with blood transfusions and recurrent bleeding. However, she had no history of NSAID use, nor did she have a history of familial blood disorders or cancer. She was tested for sickle cell and it was negative. This is 2 years prior to presentation. Her last meal was more than 3 hours to presentation. Events leading to presentation, she had normal daily activity and had no associated pain. I welcome the audience to ask for feedback whether they have any additional information that they would want to know at this particular point of this case.
Feel free to post your questions in the chat. I will read them and we'll read them out to the presenter. Team, any additional information you would love to know about this case? Okay, looks like the audience is satisfied at this point. Possibly we could hear from the expert too. Is there anything you would want to know about this patient, Dr. Okello?
Yes, thank you so much, team, and thank you for for the invite to try and digest this case with the team. In the history, I would love to know how many transfusion this baby possibly got within these 2 years, and yeah, and if they did any other, say, blood test, like say peripheral blood film before, and they have any report.
Thank you, Dr. Okello. Dr. Lunku said there are some questions here. Was there any history of upper GI bleeding in this patient? And then someone would love to re-echo the presenting complaint of this patient. Bisiku Francis, the labs will be discussed a little bit later on, so hang in there. And then Emmanuel Opolot would love to know what was the school calendar of this child and the immunization schedule. Some of the questions may not be fully answered because this was an emergency patient, but let's see what Dr. Lunkuse has for us. I hope you've taken note of the questions.
Yes, please, I have. To answer the questions from the expert, the mother reported that she recalls only the the number of times the child was transfused in the previous year, and she was admitted thrice throughout the year on 3 occasions, whereby averagely she would receive 6 to 5 units of blood on those admissions.
Thank you so much.
There were no other blood tests that were carried out except the HB electrophoresis, because they were suspecting the child had sickle cell anemia. Then for the question on whether there was a history of upper GI bleeding, no, there was any noted history of upper GI bleeding, and any history of abdominal pain. Yes. Then to re-echo the presenting complaint, this is an 8-year-old female who presented with a history of chronic anemia for 2 years that was managed with blood transfusions. So she presented in the emergency department with soiling of her underwear with fresh blood. She had no history of abdominal pain. She had normal bowel habits, as well as a normal appetite. So while in the emergency department, secondary survey was done. The patient's neck was soft, and the patient had no jugular venous distension on the hepatojugular when a hepatojugular reflux was done. Chest, the patient had no bruising, no ecchymosis. The chest was clear with equal bilateral air entry. The abdomen was of normal fullness, soft, non-tender with no palpable masses. And there was no urethral or vaginal bleeding noted, and no external vaginal lesions. Parectal exam, there was no external lesions or fissures around the anal orifice. And a nodular mass was palpated in the anterior rectal wall. The examining finger had frank blood, however, no melena. The extremities were pale and warm. The neurological exam, the Glasgow Coma scale was 15/15, and the patient had no focal neural deficit. The skin had no visible lesions, no rashes or scars. The ED interventions done at this point, we took off blood samples for a complete blood count, grouping and cross-matching, liver function tests, renal function tests, as well as a coagulation profile. The patient was given 500 mils of normal saline, 2 mils of vitamin K. It was given intravenously, 250 milligrams of tranexamic acid, which was also given intravenously, as well as 1 unit of packed cells. The patient was also given intravenous ceftriaxone, 1 gram, as well as metronidazole, 125 milligrams. These were given empirically for prophylaxis. The labs and imaging. So the CBC had the abnormalities on the CBC were basically the hemoglobin, which was 6.72 grams per deciliter, and the reticulocyte, which is low. The reticulocyte count was high of 1.91%. However, the white blood cell count was normal of 5.68 microliters. The red blood cell count was also normal of 3.31 times 10 to the power 6 per microliter. The MCH was also normal of 30.2 picograms. The MCHC was also normal of 33.2 grams per deciliter. The platelet count was also normal of 281. Yes. The blood group, the patient was blood group O, rhesus positive. The renal function tests and liver function tests were normal. The clotting profile was normal, whereby the patient's prothrombin time was 11.3 seconds, and the international normalized ratio of the patient was 1. And the imaging that was done was an X-ray, and I would love someone from the audience to read for us the chest X-ray. Anyone in the audience willing to read for us this X-ray?
Remember, this is a safe space. We are learning together. Assume you are on board and this is a patient this is an X-ray you have to interpret. So please feel free to come in and interpret the X-ray for us. We have a hand up, Kalimuzo.
Good evening. Yes, the question was to interpret the chest X-ray.
Yes, sir.
Okay. I think the first thing that we're supposed to do when we're interpreting the chest X-ray, normally we look for the demographics and the orientation of the X-ray. So I can't see very clearly here, but it looks to be, it shows as if it's AP, upright, an erect chest X-ray. And that would be also told from the orientation of the clavicles, since they are not oblique, but they are like more horizontal. So that shows that it's an AP position, AP orientation, sorry. Then from moving from the orientation and the demographics of the patient, we also have to look at the anatomy of the chest X-ray. So we'd have to look at the ribs to see if it's a good quality chest X-ray. The ribs, normally anterior ribs, have to be more than 9 visible, and then posterior, I think more than 10. However, I'm not sure. Then from when we have confirmed that these ribs are visible, that means that there is good penetration, and this is demonstrating a good quality X-ray. Then from moving from the ribs, you come to the soft tissue anatomy, which is now the lungs. You have to look at the lungs if their bronchovascular markings are present to ensure that this is a lung and it's not air or fluid. Then you also have to look at the hemidiaphragms for each, the right and left lung. And in case they are blunted, the costophrenic angles are blunted or the hemidiaphragms are raised, then you will be suspecting an air fluid level. But in this case, I'm not seeing significant displacement of the hemidiaphragms. Then we move from that to the heart. We also have to know that we normally measure the heart's enlargement by the diameter of the X-ray versus the diameter of the heart itself, of the full chest X-ray versus the diameter of the heart itself. And if it's above 0.5, then we would term it as, it would be safe to say that the heart has enlarged, and then you can go for further investigations according to the findings you've got from the X-ray. Then also on the lower side, the left, okay, on my right hand side, but it shows left on the X-ray, you can see some of the gut contents, which are and the lower below the left lung, according to the orientation of the X-ray. And also, I had forgotten, we also look at the trachea position and see if it's midline or if it is shifted to the right or left. Yes. Then also for the lungs, we also look if there are any consolidations to rule out pneumonia or tuberculosis. And the location of the consolidation can also tell you the nature of the disease process. Or if it's a traumatic case, we look for air fluid levels, which could signify pneumothorax or a hemothorax. Yes, that's what I can contribute. Thank you.
Thank you. Maybe could you tell us if there is any pathology or not, like any positive finding on this X-ray? What would you conclude from the interpretation?
So far, according to what I'm seeing, my concern mostly goes to the heart. It seems to be outside the normal shape. So, I see like almost like a water bottle appearance of the heart. So my suspicion goes there. However, I'm not sure to be exact. In the lungs, I see the bronchovascular markings, but I don't see a significant consolidation or maybe enlargement of the hilar vessels. So I would think in line of a cardiac issue, and also maybe slight deviation of the trachea.
Okay, thank
However,
you.
it can
Okay, thank you. Over to you, Dr. Lunkuse. You can guide us through the patient.
Thank you so much, Dr. Kalimuzo Joseph, for your contribution. I'm going to interpret the X-ray using the ABCDEs. If you look at the airway, yes, there's a slight deviation of the trachea. However, if you look at the carini and the bronchi, there is no significant abnormality. Breathing, the lung fields have no opacities, infiltrates, consolidations, or any other abnormalities that can be noted. For the heart, the cardiac size is normal, as well as the cardiac borders are also normal. So personally, there were no noted cardiac abnormalities. Yes. For the diaphragm, there was symmetry of the diaphragm, and on the left side you can see the air fluid level, the air, within the intestines. Yes, and basically there are no abnormalities in regards to the diaphragm. And for everything else, there were no tissue or bone abnormalities. So typically, this X-ray was taken as a normal X-ray. Yes, thank you. At this point, I would call the expert for his opinion on the differentials at this particular point and any additions in regards to the management plan of this patient.
Okay. Thank you, Dr. I love the way you really brought this patient from the history to what you guys have done. However, I would love to make a general comment that most times in the ED, most of when we work, our focus is majorly on, first of all, stabilizing these patients, and it's not basically arriving at maybe diagnosis. I love it that you asked me to bring out possible differential that we could be having for this baby girl. And actually, it is the differential that should actually open up our mind to try and see how best to help this child. So as an emergency physician, we focus so much on the ABCDE approach, which was also quite given. And if you look at the ABCDE approach, it appeared like literally everything is, it didn't look this bad. And my thought on that is because this has been a chronic ongoing problem with the little one. So the body has kind of compensated. But as the child has appeared in our ED, I would say that I'm first of all going to start literally managing as we think through what could possibly be going on with this baby. So the airway they told us is patent, which is okay. The breathing, they're saying she's spontaneously breathing and has no features of distress. This is where, as an emergency or someone working in an emergency, if you combine having severe conjunctival pallor with the BPs, which is normal for age, and then the pulse rate, which is also normal for her age, she's literally not showing any sign of shock. But in the breathing, we really want to supplement this child with oxygen because, as you know, perfusion is blood flow plus oxygen. But now, what is supposed to be the biggest carrier in this child, however normal looking the child is, the child can easily trip. And as most of us, we could know that children, they have a very small window for jumping from this normal looking to worse. And also, it is also very easy if you manage a child well from jumping from worse to actually better in a very short period of time. So, however, this child is not having any sign of distress or something, you might actually put an SpO2 and you find the oxygen saturation is normal. But we need to supplement this child with oxygen. And then in the saturation, we've talked about conjunctival pallor. So if we think around this is a child who has been chronically bleeding. So we could think around any other thing that could be causing this severe bleeding, ranging from infectious causes to possibly a malignancy. They say diseases do not read books. And we may, because we have heard stories that they do not have any history of a tumor or something like that, but let's think around together. This could be worst case scenario. This is a baby girl. We do not know what could be really taking place, but we could think first. I was also looking at some comments. Someone thought first this could even be physical abuse, or including a sexual abuse that could actually be happening to this child. And because of our age, most times they're not able to tell us. So as you're managing this child, you're thinking along that as well. Infectious causes, you see children, most times the hygiene, even the feeding is not really very nice. So it could just be having an infectious cause like possibly colitis, gastroenteritis, or even some sort of anaerobic dysentery, which is kind of presenting, giving us all that presentation of blood in the pants. The other one could be, like if you look at now, a tumor, could be like possibly an hemorrhage, could even be a fissure. However, fissure, we should be looking at asking for pain and the rest, which I'm told, I'm not sure if there was pain per rectum, but those are all thoughts that we should have in our minds as we think about caring for this child. So being a girl, I would employ us as we are managing. So I was still talking in saturation. So however much we are looking at everything normal, like I remember I told you at the beginning of our discussion that this child could look normal, but it is very easy for her to change from this looking, from all these normal vitals to getting actually worse. So we need to be ready. So in the ED for this child, we have to put 2 large bore cannulas. Being an 8-year-old, if the nutrition is not so bad, we could put even 2 green cannulas if possible, but in this case, I would prefer at least pink cannulas, 2 of them, and then we can continue to do those other tests, and then we take out blood samples, and this blood sample, the reason I ask, possibly the last time the child was transfused, because you want to bring out everything, like possibly a blood malignancy or something which is a coagulopathy, which is causing all that. So you want to take out blood sample to even for peripheral blood smear to just do coagulation property and then the disorder. And then you also want to look out for any endocrine disorders that this child could also be having. So that is what I would say. So I'm glad that most of the cases I mentioned are non-gynecological, but you could also think of gynecological causes in this child. That most time, this could even be a foreign body, that, children at some pre-pubertal ages, sometimes they like pushing things around. Some could have pushed something in the vagina, or even could have pushed something in the rectum. So we should be looking at something there. And then vaginitis, from even an infectious cause, so just dryness around that mucous membrane. And then I could also think of precocious puberty, however much the has told us that there is not so much of prepubertal signs that we are able to see this. Or worst case scenario, could be thinking of an ovarian pathology, however young looking she is, could be a functional cyst or even a tumor which is producing some sort of estrogen and then sloughing off the uterine wall and leading us to such kind of bleeds. So that is in our E. And then D, they are saying the child already ate like about more than 4 hours. I mean, more than 3 hours. However much the child also looks great, I would still think in our emergency, we should be looking at monitoring this child's blood sugar level. Remember, the rate of metabolism is quite high in children. So we should be looking at sugar. If I do not have a random blood sugar machine, this is a child I would actually give D10 and then just continue to monitor because the rate of metabolism is high. On exposure, I did not see much of the things, but because our focus was looking at petechiae and the rest, or any other things that could really point to something. But here we could do the rectal exam to try and help us rule out all those, hemorrhoid, or look out for a fissure, or even basically to try and identify the type of what of blood that is there, and then with that we could do stool analysis. That should also help us rule out any amoebiasis or E. coli related issues, or even dysentery. So that would be my opinion as far as we have come with the story. I would request the audience, if they also had anything, if someone asked something they wanted to add, they could add in this case, but that's my opinion. Thank you.
Thank you, Dr. Okello. Our time is rushing, so we shall just wrap this up. Dr. Lunkose, maybe you would showcase for us what the care was like, and then we shall pick up from the audience after your presentation. Thank you. In the next 2 minutes.
So the ED course of this patient, after initial evaluation, she was moved to surgical ward with concerns of bleeding from a rectal mass, pending lab results, and anticipating blood transfusion. The overall hospital course was the patient was admitted on surgical ward. She was transfused with 5 units of packed cells, and her hemoglobin count improved. She was reviewed by a surgeon. Examination under anesthesia with biopsy of the rectal mass was done. The patient was stable and discharged after 13 days to be reviewed the following week with the histopathology results in the outpatient clinic.
Okay, thank you, Dr. Lunkuse. Maybe up here before the expert comes in to give us the pitfalls and pitfalls, I would like to request, there is a question that is very important in the chat. Someone would love to know, this patient had normal ABC assessment, and in the explanation or in the care that Dr. Okello gave us, he recommended supplementation of oxygen, even in the babies had a normal, seemingly normal B. This person would love to know, wouldn't it be a side effect of exposing this baby to reactive oxygen species? I would love Dr. Ambrose to help us expound on that. And then also would love to know, still, it's a part of the ED workup. Why didn't they do an ultrasound and instead did a chest x-ray? Or what could be the recommended radiological investigation per se for this patient who had rectal bleeding? Dr. Okello would help us enlighten on that area. Thank you. And then you would pick it up from there to give us what are the pearls from this case that you would love to highlight for us. Thank you.
Thank you so much. That's a very wonderful question. I love the aspect of reactive oxygen species. So yes, it is important that we also have to look out for reactive oxygen species. I mean, oxygen radical, free oxygen radical that could come because of oxygen. But in this case, where we are giving the oxygen, remember the blood carries hemoglobin, basically carries hemoglobin, which is important in this case. The HB has really been dropped, and yet that means that we have reduced the oxygen carrying capacity of our blood. So giving blood in this case, actually, I don't think to really bring those free oxygen species and the reactive oxygen species to cause maybe cell damage or the rest, but supplementing them is literally going to help this child in recovery. You know, oxygen is actually very important in wound healing. So that's basically why we would give however much everything is appearing to be normal. Otherwise, thanks for that question. So is there any question that I've left and I've not? If I've forgotten, maybe you can, and you could remind me if there's anything I've left I've not talked about.
No. I think that's fine. Maybe what
Okay.
you highlight for us is the key investigation you would have wanted for this patient, because there is a concern of why an X-ray was done, not ultrasound.
Yes. Yeah, thank you. That's also a very nice question. So actually so I know that is why in the ED for us, we are really literally following our ABCDE to make sure we really do not forget anything that could possibly be important. So actually I would have actually recommended a podcast like the person who asked also could have asked, because the podcast would be able to tell us if there are any intra-abdominal bleeds that we can see or any features of peritonitis, which can actually help us even if we are not able to access an X-ray. So at the other key investigation that I would have loved for this child, like first the podcast, the CBC, which is already done, kidney function test, the renal function test, which was also done. I would love to do, or would want to also do stool analysis to try, and this would really need to help us identify any other infectious causes, because this bleeding, like they're saying it was seen in the pants, this could be coming from either the vagina or the rectum. So for the rectum, at least we really need to look out for this. We do stool analysis, or better still, we can also do H. pylori antigen test, as well as can even do a culture to rule out any, like would be salmonellosis, which is actually causing all these chronic bleeds. On the surgical part, we really need to remember to do a digital rectal exam if possible, or at least to have a good. I love it that they had a surgeon who managed to review this baby of ours to try and rule out for any other surgical conditions, like possibly intussusception, the hemorrhoids, and the fevers that could also be there. So moving on to the eyes, my key learning point in this case would be that the foreign body is actually a very common cause of pubertal girls bleeding or bloody discharge from around the vulva or even the what, or even the rectal area. So we should always be careful and try to be gentle to try and look out for all these children. So always rule out pubertal precocious puberty, that is on the other guy's side. Other bleeding disorders are very important, like the ITP, the clotting factor diseases that could also be, or even could be a platelet dysfunction. But I love it that they say the child has not been on any NSAIDs or anything that could have caused us to have any of this platelet dysfunction. And then always consider trauma or sexual abuse in every girl child. It is very important that most times we'll be thinking something else, and yet this problem could really be literally there at home and looking at us. We should always be able to try and differentiate between vaginal or those non-gynecological bleeds. especially rectal bleeds like anal fissure, which can easily be mistaken for a vaginal bleed, especially in a girl like this. So also we should also be looking at hematuria, which can also be misleading for a bleed, or even so we need to really do a urinalysis in some of these cases to try and look to see that it is not necessarily hematuria. Pelvic ultrasound is very essential. Like someone also mentioned, we needed to actually do a focus, which is non-invasive and we're not exposing this child to any form of radiation that would make us worry for the age. The common mistakes to try and avoid would be failing to perform a proper external exam, that is the genital exam and the rectal exam, so this comes with the failing to follow your ABCDE while you also try to manage this child in your ward, because you can actually start having some selection bias or diagnosis bias, and you start thinking, okay, this is what is coming, and you start to focus so much on it, and yet could be really something as simple as maybe even an hemorrhoid, which is causing all these issues with them. So really, we have to try and try as much as possible to not to make that mistake of being biased at the first time. So we try to follow that the rules to try and follow the ABCD and the rest. So then also possibly overlooking exogenous hormonal exposure. So like, in our setting, we have seen cases whereby mothers who have taken tablets for skin lightening, and then because they do not want their child to look dark, they also try to expose this child to those exogenous steroids, and this can actually lead to any of those, causing them to have maybe early vaginal bleeding, So we should always not try to forget that. These are some of the things. Then we should always, if you're in a setting whereby you think you may not really be able to manage this, we should not delay to refer some of these cases to places where we think they would really get better care. So as much as this problem was looking a little bit local, like localized because of bleeding in the pans, we should not always fail to remember that we could also have systemic causes, which could be causing such kind of bleeds. And then always do not assume that it is just a one-time thing, because when we heard about the chronic or intermittent bleed, we should always think about other further investigation to try and look out for it, even if the child is having mild symptoms. Something which has already been chronic or it has been intermittent, we should think deeper. And then even if the child, like here, we are looking at, this is a child who presented in the emergency department, is looking like he's fair, all the vitals are normal. And then we say, the child has already compensated. So, and then we try to not to focus so much on those deep events. So we should look at that as it might be like a timing bomb, that the child has actually arrived at our place when it is stable, but at any time can easily blow up. So those were my pitfalls and then the pearls for this case. Thank you.
Thank you, Dr. Okello. What I have learned is an emergency patient should be assessed fully, and don't always assume that it's a localized problem. Okay, thank you so much, Dr. Okello. Over to you, Dr. Lunkuse. Can you use the next 2 minutes to summarize for us our take homes from this case? And then we shall use 1 minute to listen from the audience.
Thank you so much, Dr. Okello. for the enlightening knowledge in regards to such cases. So when you're dealing with a pediatric patient that presents with gastrointestinal bleeding, there are 4 main questions that should be assessed and answered during your evaluation of such a patient. The first one is this really blood? Because there are cases where it could be pseudo blood. For example, if the patient has a high dietary, a dietary in like beetroot or hibiscus foods that could color their stool. So you also have to ask, is it really, is there bleeding from the gastrointestinal tract? Because it could be from the vagina or it could be from a urinary source. Then you have to evaluate the amount of blood that's being lost, whether it's a large amount or a small amount, depending from what the patient could tell you, or if they have pictures to assess clearly how much blood loss that the child is having. And then also you have to inquire whether this episode or this presentation has happened before and the duration and management that could have been done prior to this presentation. Quickly going, the possible differentials that could be found in patients that are between 2 years and 10 years. Fissures, usually fissures are small linear lesions. They present with pain, and the patient would let you know that the blood is fresh. It's usually fresh blood. Infections could be colitis or gastroenteritis. In pediatrics, it's usually viral infections. So yes, and then for infective causes, usually have recurrent diarrhea. So usually the patient could be dehydrated and could have electrolyte imbalances. So you have to watch out for that. Then systemically, they'll present with fevers and sometimes they would have pain. Then the tumor-like differentials include hemorrhoids, polyps, and vesicular malformations. Intersusceptions are also common in pediatric cases, and usually they present with current jelly stools. That's the characteristic finding of the stools, and they also have intermittent pain. Inflammatory bowel diseases, usually this is Crohn's disease, as well as ulcerative colitis. They present with recurrent diarrheas, and usually the patient will tell you that their pain is relieved as they're passing stool. Then another possible differential is celiac disease. This is triggered by gluten intake in allergic kids. So you try and assess the nutritional, like the nutritional status of the child. If they have noticed that when they take gluten-rich foods like wheat, it triggers an episode. Then there's also a possibility of the child having hemolytic uremic syndrome. This one has a classic triad of the patient will present with anemia, uremia secondary to an acute renal failure, as well as thrombocytopenia. And they will report for having had a diarrhea 1 to 2 weeks. Then it could be Henoch-Schönlein syndrome. This is associated with a palpable rash, and usually if the child, it can also be associated with intersusception. So that's something you should look out for on your examination, and also have it in mind as you're managing this patient as a whole. They could also have a peptic ulcer or rectal ulcer syndrome. Usually for this case, peptic ulcers present with burning epigastric pain, and if there's a perforation, the patient will let you know that they experienced acute onset of severe epigastric pain, and they need to be managed urgently, because there's a lot of intra-abdominal bleeding that can happen, and their hemodynamic status will be altered. In the emergency room, it's important to recognize and anticipate massive bleeding. This will be noticed on altered vitals. Small to moderate bleeding in chronically anemic patients can cause instability, so there is need to take note and take note when you're trying to triage them and be able to solve the problem. Also, you have to be able to ascertain whether they're having melena stools or copious fresh blood, or a mixture of both, because some differentials could have a mixture of both fresh blood and melena stools. like Dr. Okello had previously told us, it's important to place two large bore cannulae, and it's also important to do blood grouping and cross matching because you're anticipating this patient to have a blood transfusion. Don't miss high risk conditions like cancer, bleeding disorders, ruptured peptic ulcers, ruptured aortic aneurysms. These ones will present in children that have a connective tissue disorder. Yes, that's to wrap up our case presentation for today. I will love to acknowledge my mentor, Dr. Robert Wangoda, a junior surgeon at Masaka Regional Referral Hospital, as well as today's moderator, Dr. Anne Kaguna, an emergency physician.
Okay, thank you, Dr. Lunkuse, for the case, and thank you everyone for hanging in here. This case has taught us that we can have different presentations in the emergency department, and our goal is to always assess for what is the worst case scenario, fix the issue, and then make a final diagnosis. But we have to ensure that in the first 5 minutes, we've fixed whatever could kill this patient. That is through our primary survey. And Dr. Okello has taught us greatly how to approach this patient. I hope we've learned a lot from this case. We welcome cases every month. We have a case which we discuss with an expert and a mentor, and we welcome cases from both residents and from medical students. You are welcome. You reach out to our secretariat. Lunkuse, help me project the next slide. We have Dr. Bonaventure. We have Dr. Andrew Trinamasiko. You can reach out to Okumu or Dr. Jimmy Atiera, any of us that is closest to your institution. You can reach out. Let's learn from those amazing cases that you get to interact with every day. And let's see how emergency medicine can turn the world around. Once again, thank you everyone for tuning in today. I don't know, is there anyone over the next 1 minute that has something burning to pass on? If none, would love to bring this chat to a close. Okay, thank you everyone. Apologies for not sending in that. Someone is asking if we could send in the link earlier for future presentations. That is well noted. We shall do better next time. Thank you. Thank you once again for tuning in. Have a blessed night.
Have a good night, team.
Have a good night.
Have a good night. Thank you for attending.